Hello everyone, my name is Christopher de la Peña. I'm an MPH candidate at CUNY SPH, and I'm excited to present my capstone project evaluating policy options to improve hospital price transparency in New York State. Today I'll briefly walk you through the background and context of the issue, the methods used, key findings and their implications, and conclude with policy recommendations and directions for future research. Let's start with the background. The rising cost of healthcare and its financial burden remain critical concerns in the United States. According to a recent report, as shown in Figure 1, 3 out of 4 adults are somewhat or very worried about affording unexpected medical bills or the cost of healthcare services for themselves or their families. This fear has real consequences as financially worried individuals are 2 to 3 times more likely to delay or forgo care. To address this, the CMS launched the Hospital Price Transparency Rule in 2019, requiring hospitals to publish comprehensive pricing data and a display of at least 300 shoppable services. However, compliance remains a problem. Nationally, over half of hospitals are still non-compliant, with New York ranking 31st among states at 40% compliance rate. This highlights the need for stronger state action. My project evaluates the potential impact of state-level policy alternatives to improve hospital price transparency, which would ultimately help patients make more informed, cost-conscious healthcare decisions in New York. This, I applied the CDC Policy Analytical Framework, a structured evidence-based process with 4 key phases. Phase 1, I conducted an epidemiological synthesis from peer-reviewed literature to quantify healthcare cost burdens in New York and applied a racial equity impact assessment to evaluate disproportionate impacts of hospital price opacity. Phase 2, I performed a systematic scoping review across multiple databases to identify 3 key policy alternatives. Phase 3, I used a health impact assessment to evaluate the potential health effects of each option, conducted a cost assessment to categorize financial demands, and completed a stakeholder analysis to gauge political visibility. Finally, in Phase 4, I ranked the policies by public health impact, economic considerations, and political visibility to identify the most promising approach for improving hospital price transparency in New York. The first policy option recommends increasing financial penalties for non-compliant hospitals based on the idea that stronger penalties lead to better compliance and more accessible pricing for patients. Similar measure in Colorado resulted in hospitals rated as good increasing to 48.5%, while poor ratings dropped to 15.8% after implementation. In New York, this policy would add administrative demands on the Department of Health and Attorney General with limited revenue from fines. It's expected to face opposition from hospital groups but support from consumer advocates. Key concern is that smaller hospitals may be disproportionately impacted, struggling to absorb fines, while large systems may simply pay with little change in behavior. Also, even with better compliance, patient use of price data may remain limited if the information is unclear or hard to navigate. The second policy option proposes creating a centralized state-run platform that combines hospital price data with quality metrics. The goal is to empower patients to compare cost and care quality, which can promote competition and reduce price variation. New Hampshire's health cost program showed success, lowering imaging costs by 5% for patients and 4% for insurers, saving an estimated $11.6 million for patients and $53 million for insurers. While the policy requires substantial initial investments in technology, staffing, and maintenance, its long-term savings potential makes it highly attractive. Politically, it's very feasible as it avoids penalties, making it more palatable to hospitals, and has strong backing from advocacy groups. The main limitation, however, is access. Patients with low digital literacy, language barriers, or poor internet access may struggle to use the platform effectively, limiting its full impact. The third policy option focuses on training hospital financial counselors and providers to help patients understand care costs at the point of service. The aim is to integrate cost discussions into clinical care, promoting shared decision making and preventing surprise bills. Research shows that patients report less confusion and fewer care delays when providers openly address costs. This option has relatively low implementation costs that is mainly tied to developing training materials and staff education. It directly addresses health literacy and trust issues, which are especially critical for underserved communities. However, its impact may be smaller in scale since success depends on individual hospitals and providing providers choosing to adopt and sustain the program. Politically, it will likely gain support from community groups and patients, but it may not substantially change overall hospital pricing behavior. This analysis highlights option 2 as the strongest approach, as it offers the highest public health impact, empowering patients to compare cost and quality, promoting competition, and reducing price variation. It also offers the highest potential cost savings, despite it requiring upfront investment in infrastructure and staffing. Lastly, it also stands out for its high political visibility as it avoids financial penalties and has strong support from patient advocacy groups. Why does this matter though? Well, 85% of uninsured adults struggle to afford healthcare, compared to 47% of those with insurance. Also, racial disparities are striking. 60% of adults and 65% of Hispanic adults face affordability challenges compared to 39% of white adults, despite the Black and Hispanic populations making up just 13.7% and 19.5% of the US population versus 58.4% for white adults. This data clearly shows that healthcare affordability disproportionately impacts marginalized communities and that improving hospital price transparency has the potential to reduce financial toxicity, improve affordability, and play a critical role in reducing health inequities in New York State. That said, the study has limitations. New York hospital compliance data lacks detail by hospital size, IT readiness, and patient demographics. Additionally, societal and individual costs of poor transparency remain unmeasured, and the costs and benefits of each policy alternative were not quantitatively compared. For future research, I recommend developing a more robust, disaggregated dataset including hospital and community level factors. Future studies should also directly quantify the costs and benefits of addressing hospital price transparency in the state, as well as conduct cost benefit analysis for each policy option. Conclude, improving hospital price transparency in New York State offers substantial cost saving potential and is critical to advancing health equity and reducing financial barriers to care. Despite federal rules, compliance remains low, and when data is published, it is often not accessible or usable for patients, limiting its real world impact. Among the policy options analyzed, establishing a centralized, standardized public platform that integrates both price and quality data stands out as the most effective and feasible approach. This solution not only addresses compliance, but also empowers patients to make more informed healthcare decisions, which can ultimately reduce disparities and improve affordability across the state. And as we strive to reduce financial barriers and promote equitable access to care, one truth remains clear. Improving hospital price transparency must be recognized as a public health imperative. Thank you.